In this case study, you'll be managing a COPD patient with air trapping, and current ventilator settings are the following: AC volume control with a tidal volume of 700, a respiratory rate of 20, a PIP of 5, FiO2 of 40%, and a flow rate set to 30 liters per minute. The most recent ABG results on these settings are a pH of 733, CO2 of 66, and a PaO2 of 65. You also note that the PIP is well above the acceptable 35 and is currently reading 51 centimeters of water pressure. And your patient's calculated ideal body weight is 70 kilograms, which means his current tidal volume is at 10 milliliters per kilogram, well outside of the 6 to 8 milliliters per kilogram range. Also, his flow waveform reveals the following. So, what options do we have? Well, it's possible that the high amount of tidal volume may be contributing to the air trapping, so we should consider reducing that to somewhere closer to our 6 to 8 milliliters per kilogram range. In this case, I'll decrease the tidal volume to 600 milliliters for now. That should immediately reduce my PIP, so when we look at the ventilator, we should see a decreased PIP. In this case, the PIP is now 42, which is still pretty high. Now you also note on the ventilator that the inspiratory time lasts for 1.2 seconds, and the expiratory time is 1.8 seconds. So let's decide to increase the flow rate, which should shorten the inspiratory time and lengthen our expiratory time. In this case, we'll increase the flow rate to an acceptable initial setting of 50 liters per minute. Now by increasing the flow, we notice on the ventilator that the inspiratory time has been shortened, and the expiratory time has been increased, allowing for more time to exhale. So now it would be appropriate to obtain an ABG in about 30 minutes or so to monitor the effects of our changes. And in the meantime, we still have other options to consider. If the ABG results are acceptable, yet the patient is still air trapping, we can consider reducing the respiratory rate, as well as listen to breath sounds. And if the patient has bronchospasm, we should consider bronchodilators and even steroids. And of course, we can always perform the expiratory hold maneuver to obtain the amount of inadvertent PEEP and use this tool as a means to possibly increase our set PEEP to match the auto PEEP, and thereby reducing any respiratory muscle exhaustion